Dr. Kara Chu. She works at the UCLA Care Center, and she is a terrific doctor who focuses a lot on HIV and hepatitis C. She is currently working on ACTIV-2. It is a study of treatment for COVID. I'm really interested to see what Dr. Chu has to say. Take it away, Dr. Chu.
Okay, so I'm going to talk to you about COVID. Specifically, I'm going to talk about outpatient COVID treatment and the ACTIV-2 trial. So, I think everyone is very aware COVID-19 has had an enormous impact on this world. In terms of number of cases at this point, this was from November 1st, but globally the WHO is now reporting over 50 million cases of COVID worldwide and almost 1.3 million deaths worldwide. And looking in LA County as of November 1st, these were the numbers. But since then, in the last 10 days, we've had over 30,000 new COVID-19 cases and 500 additional deaths. So this is having an enormous impact, and maybe some of you, I think I just got an alert about increasing COVID cases in LA, and for everyone to mask up, and others probably received that as well. So, these cases are just rising, our risk is just increasing, and we're doing everything we can in our clinical trials unit to tackle COVID-19. So on the left-hand side, the figure shows you a pie graph of deaths by age in LA County, and the vast majority of deaths are in those over 50. It's not in the most elderly, but over 50. And on the right, it's deaths by sex. Fairly evenly split, but still a little bit more of the cases of death are in females. So then turning to race and ethnicity and COVID. So in terms of absolute numbers of deaths, so this just shows of total number of deaths from COVID-19 in LA County, the race and or ethnicity group of those individuals who died. And so about half are Latino or Hispanic, and then smaller proportions, white and Black African American. But this does not tell the whole story, because these are just absolute numbers of deaths. If we look at rates of death in each population, adjusted for age, the highest rates of death are in those who are Latino, Hispanic, Native Hawaiian or other Pacific Islander, Black and African American, and American Indian or Alaska Native, with lower rates of death in Asians and whites. So I think, just looking at the split of deaths by race and ethnicity doesn't tell the whole story, and we really have a lot of work to do to reduce mortality rates across all populations. This graph summarizes the course of COVID in people who have it. And actually, it's not really COVID, because COVID represents the disease when people actually have symptoms from the virus, SARS-CoV-2. So I'll just walk you through this. Looking at the top here, you'll see the different periods in the course. So early on, no symptoms, despite having viral load detection, right? And at that point, low levels of inflammation, or maybe no detectable, it's not really well studied. But already some transmission potential, because people are shedding virus, even if they don't have symptoms. And then the next period is when people have symptoms at home, right? So at that point, there's increasing inflammation, the transmission potential is still high, but then over time, it's gonna start to decline. And then we get into the period of risk for hospitalization. And that's really around 10 days, so 7 to 14 days. So what can we do here? Because we need interventions to prevent this, right? At the no symptom stage, we need an intervention here. And we need an intervention to prevent disease, symptoms, and to prevent transmission. At this point, symptoms at home. People are isolating at home. This is where we need an intervention, a treatment now, to help people get better faster, to prevent complications, hospitalizations, and deaths, and still to prevent transmission. All right, so what are our current treatment options for those that are suffering from symptoms with COVID-19? You have to stay at home, you have to isolate from others, you have to rest, you can take medications for your symptoms like Tylenol or Advil for those aches and fevers, cold symptoms, you can take medicines for those. But really, are there any approved medications for COVID-19? There are not. There are no FDA-approved medications for the treatment of COVID-19 for people who are not hospitalized. So once hospitalized, there's actually now an FDA-approved treatment, remdesivir, for hospitalized patients with COVID-19. And there are other therapeutic options as well. Okay, so what is our UCLA clinical trials unit doing about this? The lack of COVID-19 treatment options? This is it. This is our national campaign, Rise Above COVID. And you can go to this website and please do riseabovecovid.org. It'll give you a lot of information about the work we are doing, and specifically for outpatient COVID-19 treatment, it's this trial, ACTIV-2. What is our goal in this trial? It is to rapidly and efficiently evaluate multiple treatments for COVID-19 in the outpatient setting to speed recovery, to prevent hospitalizations and deaths. It's a platform that allows us to look at more than one treatment and try to get those treatments through to see if they're safe, to see if they're efficacious, and then really eventually to get those disseminated widely. So ACTIV stands for Accelerating COVID-19 Therapeutic Interventions and Vaccines. Now this is a public-private partnership. It was started by the National Institutes of Health, or NIH, and it's really a coordinated strategy to try to accelerate the development of treatments and vaccines for COVID-19. So this work is funded by the federal government. Our CTU is highly represented in the ACTIV-2 Leadership. Dr. Currier, who's the chair of the AIDS Clinical Trials Group, is leading this network, the ACTG, that is leading this trial. And then I and Dr. Dar are both protocol vice chairs. I mentioned that we're going to study multiple agents in this trial. We're not looking for just one that works and that's safe. And so how do we choose which agents are in these trials? Well, first we want to see that there's already some evidence, typically in the lab, that shows that whatever drug we're looking at can block either the entry of the virus into cells or that it blocks the replication of the virus. We're also looking for some data that already exists in people, in humans, that the drug looks reasonably safe and that gives us a sense of the pharmacokinetics, or like how the drug is metabolized and levels of the drug in the body. And we also want to make sure that these treatments are scalable. So we need to know that when a drug is brought into the study, that we're going to be able to expand the treatment to more people. Our objectives in this trial are to see if the study drugs shorten how long symptoms last, to see if the drugs increase the loss of the virus, so that may be speeding up how quickly, or really it is speeding up how quickly the virus declines in the body. And then also we want to see, of course, if the drugs prevent hospitalizations and deaths. In terms of eligibility criteria, basically individuals have to be 18 years or older. They have to have SARS-CoV-2 infection documented through a test. And that test has to be done within 7 days of entering the study and starting study treatment. They also have to have no more than 10 days of COVID symptoms, because what we think is that earlier treatment in the course is going to actually work better in terms of preventing these complications from COVID. And they also have to have symptoms at the time that they enroll and start the study drug, because we can't really tell if a drug works if we don't see that symptoms improve. We are especially interested in people who are at higher risk for progression of COVID, so getting sicker from COVID. There are some risk factors that we are aware of at this point. A lot of people have done a lot of great work to try to identify this and to describe the risk factors for more serious COVID. In our study, we are defining higher risk as being 55 years of age or older, having high blood pressure, having a history of cardiovascular disease, so that would be like heart attacks, strokes, or heart failure, having chronic lung disease, chronic kidney disease or liver disease, or having obesity by a body mass index of over 35. So how will we tell if the drugs work? One, we are going to do nasal swabs. Two kinds. There's the kind that goes really deep to the back of the throat. That can be a bit uncomfortable. We also ask that individuals do their own nasal swabs, more in the front of the nose. And then we are actually doing saliva or oral wash collections, where people swish some Scope mouthwash in their mouth and spit that out into a tube. And we look for virus in all these samples. And we're also looking for virus in blood, We're going to have people, or we do have people, complete symptom diaries. So every day they record their COVID symptoms using the scoring system, and we will see over time if those symptoms improve, and if they improve faster in those who get an active drug versus get a placebo. And this is a placebo-controlled trial. We are going to do other tests also, just of course to look for safety, because that's an important outcome in these studies, which is to see if these drugs are safe. And so those are blood tests to look at kidneys, and look at kidney tests and liver tests, and also blood counts. And we're doing research tests to try to understand the mechanisms of disease in people with COVID, including markers of inflammation and blood clotting factors, and also we're looking at some vitamin levels and mineral levels, zinc and vitamin D. And then, of course, another important way that we monitor people is that we do see them for visits or talk to them over the phone, and we see how they're doing. So people do get monitored fairly closely through the study, and that's often a benefit. So how many participants do we need to see if a drug works? So in the initial phase, we're really looking to see if a drug shortens how long people have symptoms. Or increases the loss of detection of the virus in those samples I talked to you about, especially the deep nasal swabs. And so for that, we need 110 people per active agent and a similar number in the placebo group. And then if a drug looks good, and we assess that through interim analyses, then we're going to go on and expand the population to enroll up to 1,000, and that's what we need to see if the drug reduces hospitalizations and deaths. What are the agents that are currently in the trial, or that we expect to have in the trial? So right now we have one monoclonal antibody. It's an Eli Lilly produced monoclonal antibody. I'm going to talk to you about that a little bit more. But we are also looking into other monoclonal antibodies, combination monoclonal antibodies, inhaled antiviral treatments, and oral antivirals. Now, I mentioned that this is a placebo-controlled trial right now. There is, as I said earlier, there is no FDA-approved treatment for COVID. So the current standard is no treatment. And so right now we are comparing to placebo. All right, so what are monoclonal antibodies in particular? I think everyone knows antibodies are a really important part of our immune system. They're an important arm of our immune system. We naturally produce antibodies when we are exposed to invaders in our body, so substances that our bodies don't recognize as our own. And the goal is then to clear those substances out. So these antibodies are generally targeted towards the virus, and particularly this one region of this spike protein. I'll show you a little picture in a sec. And they were originally generally identified from people who recovered from COVID. And their antibodies or their cells were screened, and companies and people have found antibodies in particular in these individuals that were highly neutralizing. So very effective basically at blocking the virus from entering cells and thus preventing further replication. So on the right-hand side of this slide is really a picture of the life cycle of the virus. And up here you can see the virus. And the step that these antibodies block is that entry part. And then as the virus goes on in the cells, what happens is more viruses are produced, and these viruses go on to infect other cells, and that's how infection is spread in the body. Okay, so how do the monoclonal antibodies work? All right, so if you can see here, this is the SARS-CoV-2 virus. These little red spikes, those are the spikes that you hear about in the news. And normally, to enter into a cell, these red spikes will come and bind these receptors on our cells. But these green Y-shaped things are the antibodies, and they themselves bind to these spikes and then prevent this interaction so that the cells can't actually the virus can't actually infect the cells and enter the cells and then further replicate. So that's the basic mechanism of pretty much all the antibodies that are being developed. So how are they given? They are given intravenously right now, and in our trial, it is an IV infusion one time, but those levels are expected to last for many weeks. So that's partly why it's very attractive as a treatment option in the outpatient setting, because even though it's given IV, it lasts for a long time, and so its effect should go on. But there are other routes that are being looked at, because obviously IV is not very practical or scalable. So intramuscular injections, as cabotegravir is given, and then people are also using subcutaneous injection for monoclonal antibodies. The current antibody in the trial is this Lilly monoclonal antibody. It has a name now, bamlanivimab. It's also referred to as LY-CoV555. And very recently, there were some data published in the New England Journal of Medicine from a separate outpatient COVID-19 treatment trial with this antibody that Lilly sponsored, and that study was called BLAZE-1. And in this trial, they gave 3 different doses of the Lilly monoclonal compared to placebo to outpatients with COVID-19, so people with mild to moderate COVID symptoms not hospitalized. And basically, what they saw, and this was an interim analysis, so the study is not completed, and in total, about 300 people across the doses got the active antibody, and just under 150 got the placebo. And what they generally saw was that the monoclonal antibody seemed to reduce the viral load faster. And as a secondary outcome, they saw a lower rate of hospitalizations in those that got the monoclonal antibody, all the doses combined, those 300, versus those who got the placebo. So 6.3% hospitalization rate in those who got placebo, and 1.6% in those who got monoclonal antibody, an active agent. So quite promising, not proven yet. And you've probably seen this in the news. President Trump received experimental antibody treatment. That was actually the Regeneron antibodies, same mechanism, and in that case, a combination of 2 antibodies. And then Eli Lilly seeks emergency use authorization from FDA for COVID-19 antibody treatment, and then the Regeneron company also has sought an EUA. So really new news, just yesterday, the FDA has issued this emergency use authorization for the Lilly monoclonal antibody. Now, what does that mean? That does not mean that the drug is proven. What it means is that, based on the evidence from that BLAZE-1 trial that I just showed you, the FDA feels that the safety is sufficiently demonstrated enough that the benefits appear to outweigh the risks at this point, but the safety has not been fully established. So they're making this drug available for outpatient COVID-19 treatment, and the population that will be eligible are 12 and older with risk factors for severe COVID-19 or for progression of COVID-19. So a lot of the criteria for adults overlaps our trial from ACTIV-2, like those criteria that I described to you, except the age cutoff is a little bit older, 65 and older, and then the younger population has to have particular comorbidities. Now, the government has agreed to purchase 300,000 doses of the Eli Lilly monoclonal antibody over the next 2 months. But I just mentioned to you that just in LA County in the last 10 days, we've had over 30,000 cases of COVID-19. So this is really not a solution for everyone with COVID-19 who needs treatment. And it definitely is going to have an impact on our study, and we're figuring out what to do next. But we do have, in addition to the Eli Lilly monoclonal antibody, all those other treatments, including the combination monoclonals that we're going to be looking at. But we are going to figure out what we can do to try to get treatment available to more people. We've talked about COVID-19 causing hospitalizations and deaths. I think everyone's aware of like COVID-19 symptoms in general. Early on, a lot of cold-type symptoms, and then more seriously pneumonia and low oxygen levels. But what we are starting to see, and this is new, but being increasingly recognized, are what people are describing as individuals who've had COVID-19 and are long haulers. So these individuals are not recovering from COVID-19 quickly. Many are not hospitalized, have never been hospitalized, but they have these very prolonged symptoms for months that include fatigue, brain fog, rapid heart rates, kind of different neurologic symptoms, numbness, tingling, memory loss issues, still trouble breathing. And in fact, some providers are setting up clinics for long haulers. And this can be very debilitating physically, but also psychologically and emotionally. So we're still learning a lot about COVID-19. And it's really the whole spectrum of COVID-19 symptoms and disease that we want to try to prevent with early treatment. So what can you do? Please spread the word about the need for effective treatments for COVID-19 in people even before they are hospitalized. We need to find ways to prevent people from getting sick and from getting sicker. And in terms of just getting COVID in the first place, or SARS-CoV-2 in the first place, Dr. Dar is going to talk about prevention approaches. And we also need treatment to prevent transmission and thus prevent more people from getting infected. So go to this website, riseabovecovid.org. If you know of anyone who does end up with COVID and has symptoms, there is a call center, a central call center. There's information on the website where people can call and be linked to the closest ACTIV-2 site. We have 3 here in LA. We have our unit at the Care Center in West LA, Harbor, UCLA, and USC is also a site. So thank you. Let's rise above COVID.